Mine is a bit longer.
Okay, Sagar, let us see. I mean, how can we adjust? सॉरी हां मला हे ऍक्च्युअली 8:30 लाच करायचं होतं.
So we're at 8:35. Do you want to begin?
There are 26 participants, so I feel we can start.
Sure.
Yeah.
So you can introduce the topic and the first speaker, and then we can move ahead.
Right, sure. So is Sweetie ready?
Yes, sir.
Yes, very good. So we have something around 28 participants.
Okay, sir.
So I would be audible to everybody right now?
Yes.
Yeah. Good evening, everybody. On behalf of FINE, I welcome you all to another Tuesday tutorial, which we have been doing since last 6 to 7 months for all the exam going students. So this is the second lecture series in the part of our neuroinfectious disease. So last year it was a module 1 where of neuroinfection, where we have seen all the tropical neurology. So last time we included the CNS-TB, we included malaria, and we included other neurological diseases which are very peculiar to tropical areas. Hence, we don't have the much data or much literature from our Western books. In same way, to help you prepare in your examination, probably we are going ahead with another session of neuroinfections module 2, where we are considering the tropical diseases like leprosy, SSP, neurological complications of HIV, and CJD. So today the first lecture would be taken by my colleague Dr. Switi Trivedi, who is a neurologist in Noida. So she would be speaking about neuropathy of leprosy. Okay, so the questions would be taken at the end of the session. So I request Switi to share her slides.
Okay, sir. Sir, are you all able to see the slides?
Yes, yes. You can put them in the full screen mode.
Okay. All right. So the topic for good evening, everyone. The topic for discussion today is neuropathy in Hansen's disease. So why is it called Hansen's disease? Because it was discovered by Gerard Hansen, who was a physician in Norway. The topic will be discussed under the following headings: introduction, epidemiology, etiology, pathophysiology, clinical features, diagnosis, treatment, and complication, which are usual for your paper. So just a brief introduction. What does leprosy mean? It is coming from a Greek word lepra, which means scaly. It was also known in India in around 600 BC, and it's very famously called Kusht Rog, meaning wasting away or eating away, because it is marked by deformities. But although it was discovered in 1873, the first treatment only started after almost more than 100 years later in 1943. It is disease of skin and nerves, but nerve function impairment, what is more important is the nerve function impairment as an initial presentation is more common, and 55% of the patients have this. So leprosy neuropathy is one of the important differential diagnoses when you have patients of neuropathy walking into your clinic. All right, so brief epidemiology of 2018. The prevalence rate is around 0.2 per 10,000 people. And if it is compared from what it was in 1985, it was 21 per 10,000 in 1985. So we have come long way in that terms. Now it is only in decimals. But still, India contributes to 92% of the cases in the Southeast Asian region, of which 2 lakh cases have been found in 2018. Briefly about lepra bacilli, I won't give much time to this thing and pathophysiology, because more important are the neuropathy and the presentations and the newer diagnostic methods that we have at our disposal. So lepra bacilli, as we all know, is an acid-fast, alcohol-fast, gram-positive obligate intracellular bacilli. That's why it cannot be grown in a culture media. It requires 9-banded armadillo or any animal model to be grown. It has typically tropism for reticular endothelial and Schwann cells. And hello. Hello. Hello, am I audible? Hello. Hello, am I audible?
Yeah, you are audible, Dr. Sweetie.
Okay.
Only you have to make it full screen.
Okay. So the share has stopped somehow. I don't know. I'll come back. Is it being shared now?
Yeah, is it? It is shared. Yeah.
Okay, thank you. So the reservoir coming, I'll just go to this slide back. This was the one I discussed. So it takes 25 to 14 days to divide. And why we need to know this? Because single dose of rifampicin is adequate to make a person non-infectious because it takes so long for one bacilli to divide. So if a patient is infected and given a single dose of rifampicin, at least he becomes non-infectious to the household and everything, and transmission is uh, disrupted. What is the optimum temperature for growth? All we know is 27 degrees Celsius to 33 degrees Celsius. That helps in us in um, that helps us find that the lesion is in cooler areas of the skin and nerves. Uh, why we need to know about this? Because then we need to know the clinical examination areas where we will find once we have a patient of polyneuropathy in our clinic. The reservoirs are animals, mainly nine-banded armadillos, chimpanzee, magabe monkeys, which are not found in our countries. What we do found is human beings, and they are most infections are the lepromatous cases. So these are the most common reservoir in our country. The modes of transmission are, of course, droplet infections and contact transmission, mainly with highly infectious cases, the lepromatous leprosy, and the borderline BL category, which I'll discuss later in Ridley-Joplin classification. So the droplet infection causes every 1 cc of nasal secretion contains 1 to 2 million lepra bacilli. So if the patient is highly infectious, so the nasal secretions will cause the infection. Incubation period is around 3 to 5 years, but it can be as long as 40 years. Males are more commonly affected. Or if you are seeing more patients and more children of having infections with leprosy, then it means that the disease is not contained very well, and it is in not the stage of WHO ratings which we have is not has been achieved, and the disease is more transmitted. Coming to pathophysiology, as I already told you, the response of how the patient will respond to a leprosy infection when they are exposed to Mycobacterium leprae depends on their natural resistance or innate immunity. If they have a good immunity, 95% of them are not having get infection. They do not get infected. Those 5% of patients who do get infected have a spectrum of disorder depending on whether they are having good immunity, they are having tuberculoid pole, and if they are not having a good immunity where humoral response is more common, they have a lepromatous pole. Those patients of tuberculoid pole have how do we know that tuberculoid pole by clinical examination? They are having less number of good, because the cell mediated response is so good that the bacilli are killed, they are contained, and a good granuloma is formed. When the biopsy is done, we see a well-formed epithelioid granuloma with macrophages, Langerhans giant cells. No giant cells are seen in lepromatous poles. And you will hardly find any bacilli in tuberculoid pole when biopsy is done, whereas lot of bacilli you will find in lepromatous pole. Now coming to they will have more number of lesions will be more in lepromatous, they will be diffuse, whereas tuberculoid will have less number of lesions, very well demarcated, and they have rough borders. They have whereas lepromatous will have a shiny lesion because they are so diffusely involved, and there is autonomic and pseudomotor response also, that the sweat glands and everything has been destroyed. The skin becomes very shiny. Lepromatous pole is very characteristic for that. Since they have so good response in tuberculoid fluid, the lepromin test, the test for cell-mediated immunity is lepromin test. It is 0.1 ml of lepromin agent is injected, and they show a very good response to lepromin. Whereas leprometis is completely anergic. There is no midline between them is the borderline tuberculoid borderline and borderline leprometis. So this forms a spectrum of the disorder where where is the pathophysiology concerned. Also, the pathophysiology also decides whether there will be what kind of reactions will happen in these leprosy patients, especially if they are of the tuberculoid pole and borderline patients. They will have more of reversal reactions. They are delayed type reactions which have good cell mediated immunity, whereas those in the lepromatous pole which have bad immunity and they have poor immune response, they will have more of erythema and nodosum like type 2 reactions with antibody antigen complex deposition. How is the peripheral nerve damage? Now, regarding the peripheral nerve damage, these leprosy related nerve damage is mainly immune mediated. They are mostly due to either cell mediated or humoral, as may be the case, whether it is tuberculoid pole or whether it is a lepromatous pole. So once there is infiltration of the nerve cells, the bacteria enters through the nasal secretion, is disseminated through blood. It enters the Schwann cells through some predisposition to the PGL like molecules. It attaches to the Schwann cells, it gets infiltrated, and thereby starts inflammatory mediators. It causes ischemia, apoptosis, and demyelination. There is contact demyelination as well as destruction of the Schwann cells. That's why we get, and gradually it progresses to axonal degeneration. So there are 5 stages in the peripheral nerve damage. They are mainly parasitization, where the bacteria is entering the mechanically damaging or causing demyelination. Second is establishing of the disease process, where there is inflammatory response and tissue response. And third is the clinical infection, when there is nerve thickening. And then is the stage of nerve fiber impairment, where you get ischemia and apoptosis. When you get apoptosis, demyelination, more is demyelination, less of these two. This stage is reversible when you get nerve fiber impairment. When it goes to apoptosis and ischemia, then it is an irreversible stage. Next comes the clinical features. There are skin features and nerve features. The skin features are macules, papules, and nodules. There are hypopigmented or anesthetic or hypostatic patches. There you can see there is lesions. There are hypopigmented lesions. Skin lobule, ear lobules are involved, and nerves are thickened. There is loss of sensation and muscle weakness. So this is greater auricular nerve, which can be found thickened once you have a look at it. Whenever you find a patient suspected to have a leprosy. One important thing is, once you start finding muscle weakness in patients of leprosy, that it means it's a fairly advanced stage. So this is a Ridley-Joplin classification, which I have already described. It starts from tuberculoid pole and it has lepromatous pole, and between that is borderline tuberculoid, borderline, and borderline lepromatous. So in this spectrum, as I have already told, this is having very good cell mediated immune response, and this is not having so good response, in fact poor response. More number of bacilli, less number of bacilli, and more number of bacilli, and subsequently the lesions and the tests. So why there is also other classification, Indian and Madrid. We are not interested in that. Why we are we are interested in WHO classification? Because they have a therapeutic implication. They help us decide what regimen we will follow for treatment of this patient, and that's what is the final and the most important thing. So the paucibacillary have 1 to 5 lesions. Apart from this, anything else is multibacillary. Pure neuritic leprosy is usually considered a multibacillary leprosy and treated as like the same. But there is a debate regarding that. So coming to clinical presentations of leprosy neuropathy, how they will come to your clinic, how they will walk into your room. So there is classical leprosy neuropathy. They will have skin lesions. They will have mononeuritis, multiplex. Overlapping neuritis, that is mononeuritis multiplex, has so formed and so progressed that it presents like polyneuropathy. like gloves and stocking distribution. There can be cranial neuropathies. Most commonly are the facial and the trigeminal. However, there can be bilateral optic nerve involvement also. There is thickening of the nerve terms. You have to palpate. Once a patient who comes into your clinic, you have to walk when you suspect there is neuropathy. You must always check for palpable nerve thickening. Once you get that, then you have a whole list of differential diagnosis, and leprosy should be high on that list. So what you will do with these patients, they have also peripheral autonomic dysfunction like ulcers and a hydrotic skin because of the autonomic nerve involvement. Autonomic nerves are very well involved and very early involved in leprosy. So because of the number of Schwann cells, although they are very thinly myelinated, so even though leprosy has Schwann cell adherence and body tropism for Schwann cells, yet large fibers are very late involved. More early involvement is of small fibers and autonomic nerves. Why? Because the number of Schwann cells are much more in them. The number of Schwann cells in a large fiber is much less. They have a thickness. The large is, it is not large because of the number of Schwann cells. It is large because of the thickness and the cross-sectional area of that nerve. So how can we diagnose them? With skin biopsy, and the treatment is of course depending on the number of lesions. It can be multi-drug therapy, whether possibacillary or multibacillary, or added immunosuppression if there is a reaction. So what are the nerves palpable? It is very important for you to know. They are very frequently asked and very frequently you may have to examine. The most common, obviously, you will find is retroauricular nerve. Rather than most visible, I should say, not common. The most common is ulnar nerve, and the least common upper limb is the radial nerve. The next is median nerve, common peroneal nerve, and posterior tibial nerve. They are in the decreasing frequency that you will find. Cerebral nerve behind the lateral membranes, greater auricular nerve, facial nerve, obviously frontal branches, and corneal anesthesia is due to the fifth nerve involvement. That's why the eye manifestations. So pure neuritic leprosy next is very not that common outside India, but in India it is a vast majority of cases, almost 4% to up to 18% of cases may be pure neuritic leprosy. It's not that common outside India. It's not the crux of the diagnosis is there are no, the main problem with that is that there are no detectable cutaneous lesions. You won't find anything. And how can you diagnose? They can present as mononeuritis multiplex. So once a patient walks into your clinic or your hospital, they are presenting with mononeuritis multiplex. So you have to have a very high suspicion to have a diagnosis of leprosy. You have to check everything and you have to see for palpable nerves. Once you get a nerve thickening, that means you are dealing with possibly leprosy, with most common treatable condition in our country. And they also have obviously peripheral autonomic dysfunction. They are sometimes painful, and once you palpate the nerves in your ulnar groove, it will be painful. There will be nerve tenderness sometimes. So nerve biopsy is gold standard in PNL. In all other cases, you will get a lot of other things. But other thing that you can apply here is obviously high resolution ultrasounds, which I will discuss later. And apart from that, corticosteroids are helpful because sometimes these patients have nerve abscess formation and neuritis, acute neuritis. Then you have to use steroids to salvage the nerve and to prevent developing permanent deformities. Reactional leprosy neuritis, type 1 and type 2, as I've already explained. Type 1 is more commonly seen with good immune response because it has delayed type of, since hypersensitivity reaction, cell-mediated immunity is involved, more commonly seen in borderline tuberculoid or borderline and borderline lepromatous cases. The number of lesions, the number of nerves that are involved are increased involvement of the previously involved nerves. Suppose someone is having an ulnar nerve involvement, he was on treatment and he has started taking leprosy drugs. Usually within first month of the taking MDT, he can have a worsening of the lesions. We can have worsening of the nerve impairment. At that time, it is very important that you keep the patient indoors and give them steroid to prevent any permanent nerve damage. Type 2 reactions are erythema nodosum reaction. They are more common in high bacterial index cases, more than 6 usually, and they are in lepromatous, sometimes in borderline lepromatous, usually in lepromatous cases. In this case, the autoimmune reaction is due to the antigen and autoantibody complex deposition disease, and it can have systemic manifestations also. Again, the therapy is corticosteroid, thalidomide, and clofazimine. Coming to leprosy, painful small fiber neuropathies, they are usually autonomic involvement. As you know, small fibers are autonomic as well as small fiber painful pain fibers are involved, and they can present like CRPS, complex regional pain sensitive syndromes, CRPS syndromes, and severe pain, neuropathic pain. You have mostly they are having symptomatic treatment. Now, other a bit mimics, I should say, or masqueraders. Sometimes it may present like arthritic leprosy, like simulating rheumatoid arthritis with deformities and with pain associated with painful joints and painful nerve thickenings. But nerve thickening is present. That should lead you to rheumatoid arthritis, because even in patients of rheumatoid arthritis, mononeuritis multiplex is present because there are on so many drugs also and immunomodulation. Yet if you find nerve thickening, you should think of leprosy in these patients, because leprosy can have an arthritic presentation. Again, we know autonomic neuropathy, it is commonly more like complex regional pain syndrome. They are regional. You will get a history of you may get hypopigmented patches. So must always look for back of the patient. Never miss out that. Again, another presentation is late onset leprosy neuropathy. So what is this? Usually this happens after a patient has been treated and he has completed treatment after a long time. Usually leprosy occurs in 20 to 30 years of age group. This happens in usually when the patients are in 40, 50 years old or older, and they have a previous history of the treatment. The presentation is same like mononeuritis. Sometimes they may present like ataxic neuropathy with glove and stocking type overlapping neuritis sometimes, and they are very, very painful neuropathies. You have to do a nerve biopsy, and these neuropathies are mainly occurring because of the residual bacterial antigen. They are especially an immune response. So you have to give a immunosuppression, immunomodulation, commonly steroids. Again, these are some salient neuropathies, recurrent neuritis. How to know whether it is a recurrent neuritis or whether it is a long LLON, whether it is late onset leprosy neuropathy. Why? Because late onset leprosy means the patient is treated, completed the treatment, has been well for some period of time, and then after a very long, in years, they again develop symptoms, and biopsy is the gold standard. In recurrent neuritis, however, the patient will have an episode of neuritis recurring after a symptom-free period of 3 months, and they are occurring in multiple distributions. They have pure dreams. Sometimes they also present like silent neuropathy. Patient has only neurological deficits. They come with foot drop or they come with hand wrist drop. They are progressive and you don't get anything. They do not have any nerve pain, tenderness, any reaction. But you perform electrodiagnostic test and high resolution ultrasound. You will find nerve thickening. Biopsy will show features of leprosy. You won't find any. Possibly you won't also find any hypopigmented patches. Sometimes subclinical neuropathy may be one presentation, and they have normal values for voluntary muscle testing, monofilament testing. They are usually these such patients who are initial stage, usually research patients, where you are testing patients, random patients. You find a patient who is having neuropathy and he even doesn't understand why he is having that test abnormal, like neurofilament NCS is abnormal or one detection threshold is abnormal. Just when he went for a random check, he's having that, and when you go for further test, the patient is having leprosy neuropathy. These are many phases of, this is from an article that I have taken. These are many phases of Hansen's disease. Like sometimes AIDP, they can have AIDP like presentation, CIDP like presentation. One of rare, these are rare presentations like leprous myelitis, leprous ganglionitis, which was reported by Dr. Khadilkar, and it has been seen like patient presented as a case of quadriplegia with myelopathy features. and he was having on biopsy. When the biopsy was taken from the nerve root, then they demonstrated AFP. And again, we have to know the masqueraders, those patients who have nerve thickening, who have skin lesions. They think you think it is a leprosy, but they may have other diseases like Tanger's disease or neurofibromatosis. Again, you should have also a list of differential diagnosis for nerve thickening, like apart from leprosy, like amyloidosis, CIDP, and many hereditary neuropathies, HSM, and those things. What are the special forms of leprosy? They are luceal leprosy. They are mainly there is diffuse skin infiltration. You won't find any patch. The patient will have loss of eyebrows. There will be madarosis, and they will have extensive sensory loss. They won't know that they have a sensory loss. It's only when you test it that they have, but they have it extensively. Touch and pain temperature widely impaired. Histoid leprosy is usually seen in lepromatous leprosy, borderline and intermediate cases. They are having in those who are taking inadequate treatment. Usually, they develop histoid leprosy with large nodular lesions, which are skin colored or reddish sometimes, and they have a lot of bacilli on biopsy. Again, coming to diagnosis, they have to have one of the three cardinal signs: hypopigmentation, nerve enlargement or thickened nerve, or weakness in their supply distribution, and in a biopsy specimen or a skin specimen, presence of acid-fast bacilli. So, as I have already mentioned, in pure neuritic leprosy, you won't find these two. You won't find any skin lesion. You won't find any acid pass. You won't find the skin lesion. So only these two are present. There is enlarged nerve with loss of muscles, loss of sensation or muscle supply weakness, and you have to suspect that. In these PNL patients, the nerve biopsy is a gold standard. So how do you diagnose? By clinical symptoms, by slit skin examination, biopsy of skin or nerve, immunological tests, electrodiagnostic studies, and high resolution ultrasounds. So in clinical examination, what is the salient point that you should remember? That temperature and pain sensations are decreased early. Vibration and position sense are usually normal till end, not in extremely end-stage patients. Usually, deep tendon reflexes are almost preserved in leprosy patients, even in end-stage disease, even in advanced patients. When you do a bacteriological examination using nasal scrapings or skin ear lobules or skin smear or skin biopsy, if there is absence of bacteria, there is paucibacillary. Presence of bacteria, even one single bacteria is multibacillary, you should straight away shift for multibacillary regimen. Now regarding biopsy, what is the new thing regarding biopsy? There is now usually when a biopsy is confirmed, to increase the yield of the biopsy, there is a combination of fight per acoustic and multiplex PCR is used. So it increases the chances of detecting the biopsies and detecting AFB in the biopsies. If it is a skin biopsy, full dermal thickness should be used, we know that. And if it's a nerve biopsy, usually a pure sensory nerve, sural or radial in the radial cutaneous nerve should be used, or more accessible nerves which causes minimum damage should be used. This is a histopathology slide. This is gram stain which shows well-formed granula, usually in the tuberculoid spectrum. This is white Paraco stain, usually showing in the lepromatous leprosy category. Patients showing lepromatous, showing the Mycobacterium leprosy in the macrophages. Immunological test, I won't emphasize much. They are mainly for completing the list of the. We don't usually order these tests. They are just for the mere sake of completing the list. So, what are the tests for cell-mediated immunity? It is lepromin test, and what is new in that? Lymphocyte transformation test and leukocyte migration inhibition tests has been developed. Why are they used? They are used to detect subclinical infections. Those which I already subclinical neuropathy, those who present to us uninformed, and suddenly they are on testing and on NCS exam they are having these features. And test for human response mainly for the lepromatous category patients. They are FLA-ABS test used for subclinical infections, monoclonal antibodies, ELISA test. More, I would like to highlight on HRUS, that is high resolution ultrasound and color Doppler. These patients, those who are having nerve thickening, it is very good to have nerve ultrasound these days at our disposal, because sometimes there may be anatomical nerve damage. You may do a nerve conduction test and it may turn out to be normal, because only after a certain number of fibers we are testing the entire nerve, entire fascicle, when we are testing nerve conduction studies. So when we are testing for the these electrodiagnostic studies, their function may be preserved, yet they have a disturbed anatomy. At that time, ultrasonography still may show you the ultrasonography still may show you lesions. Normal nerve is usually oval to round with a honeycombing pattern, and the nerve fascicle is surrounded by hyper equal perineurium. This is a normal ultrasound finding. What you will find in leprosy patients, there will be focal thickening, hypoequosity, loss of vascular architecture. They are suggestive of inflammation. Sometimes you may also find fibrosis, fusiform nerve thickening. You may also form nerve abscess. They are more common in PNL, and cross-sectional area above 0.08 centimeter is always a good predictor of nerve thickness. So what are the treatment guidelines? You all know what are the conventional drugs. Rifampicin once a month and clofazimine dapsone. Duration is 12 months for multibacillary, 6 months for paucibacillary. Usually clofazimine and dapsone are daily dosing, whereas clofazimine and rifampicin also have a once a month dose. And paucibacillary only has dapsone daily dosing with rifampicin once a month. How do you treat a drug-resistant leprosy? When to know that drug-resistant leprosy is there? First is by the clinical features. Second is by obviously bacteriological index. You see a patient's bacteriological index was declining. Suddenly it has started again rising. Either the patient has stopped taking the drugs or he has developed resistance. So we have to check from history and exam. If they have only rifampicin resistance, you have three drugs, oflofluoxacin and minocycline plus clofazimine. You have to give for first 6 months, or you can give ofloxacin and clarithromycin. Once from ofloxacin, minocycline and clarithromycin, 2 drug has to be given along with clofazimine, and next 18 months only one of the second line regimen along with clofazimine. If they have both rifampicin and ofloxacin resistance, then we have to give both clarithromycin and minocycline and clofazimine for 6 months. Again, between clarithromycin and minocycline, you can choose one along with clofazimine. Clofazimine is quite expensive drug. So, what are the complications, side effects of the drugs, reactions, and disability? I have already discussed reactions. They are type 1 reversal and type 2 reactions. They are ENL. I won't again spend time much on them. But the thing is that how to differentiate the two reactions are, the other organs are not affected. General symptoms are not common in reversal reactions, whereas ENL, other organs like eyes, kidney, intestines may be involved, and there will be fever, joint pain, red eyes, with systemic symptoms might be there. ENL involves newer areas. Usually, reversal reaction occurs in areas which are already involved. How do you treat type 1 reaction? This mild reaction. If it is a mild reaction, NSAIDs and high dose steroids. The thing for in giving steroids in reversal or any reaction is that you should start with high dose, keep it for some time until there is improvement, and decrease very slowly until you have reached 10 milligram. Decrease it every 5 milligram every 2 or 3 weeks or 4 weeks, and then reach a dose of 10 milligram. Keep that 10 milligram another for 1 month, and then again taper down. Otherwise, they will recur. Other things which cannot, if the reversal reaction does not respond with steroid, you can try cyclosporin. They should be treated as an emergency, because the reactions will cause permanent deformities. Treatment again for ENL is prednisolone, clofazimine, and thalidomide. That's why clofazimine is good. Because apart from treating the bacilli, it also prevents the reactions, especially ENL. So severe mild reactions, you can give aspirin. Again, severe reaction, you have to give prednisolone in the same fashion that you have given in reversal reaction. For ENL, you have to give thalidomide. You can use thalidomide. Thank you.
Thanks, Dr. Shruti, for that comprehensive review of leprosy. It was really indeed a good lecture. Questions will take later. So now we will move on to the next topic. And before that, I just request all the speakers to, as much as possible, stick to the time frame. We have got 15 minutes each and we must have some time for discussion. So I request all of you to please be on time. So next we have got Dr. Sudhakar Pandey. He is from KGMC Lucknow and he's going to speak on SSP. We all know that most of the research papers on SSP, they have come from Dr. Garg, who is from KGMC Lucknow. So I request Dr. Sudhakar Pandey to start his lecture on SSP. Dr. Sudhakar, please.
Thank you. Thanks a lot. Good evening to everybody. So I will discuss about SSP in a bit detail, but I will stick to time frame which you have provided, and I am going to share my slides now. So am I audible to all of you? Okay, so I am going to start. So to everyone, I am Dr. Sudhakar Pandey. I am consultant neurology in Vedanta Hospital, Lucknow. I have completed my MBBS, MD, and DM all from KGMU, Lucknow. And now the topic for today's discussion is subacute sclerosing panencephalitis. So I have divided my whole of this topic in following subheadings, which I will be discussing one by one. Now, first of all, this introduction. So as we all know that subacute sclerosing panencephalitis is a basically devastating progressive neurodegenerative disorder of central nervous system. And it is caused by persistent infection of brain by aberrant measles virus. So incidence in India, as per se by Saha et al., it is 21 per million population. So it is a huge number for India because we are a populous country. And affected patients usually have multitude of symptoms and signs in variable combination like behavioral changes, myoclonus, mental deterioration, seizures, extrapyramidal dysfunction, or visual disturbances. So disease is eventually having a progressive downhill course, and it leads to death in most of the patient within a few years. Until now, there is no specific and definitive therapy protocol for SSP, although there have been various agents which have been tried with variable success, but till now there is no definitive guideline or therapy protocol. And out of all those agents, the combination therapy of oral isoprenosine and intraventricular interferon alpha therapy is most effective one till now for the treatment of SSP. So coming to epidemiology, it has been reported from almost all parts of the world. And as in Western world, it is they are developed, so it is considered a rare disease. But in our country, like India and neighboring countries, which we are developing country, so we are getting a lot of patients till now in spite of good vaccine coverage and other things. So most of the patients of SSP, they are having a history of primary measles at the 1 or 2 years of the age. And it has been reported that the high incidence is seen in boys as compared to girls, and male-female ratio is usually 3:1. And incidence is higher among rural children than children with 2 or more siblings and children with mental retardation. It is also commonly seen in children with lower birth order or those children who are living in overcrowded environment. Then because of widespread immunization coverage, it has reduced, although more than 90 or 95%, I should say, reduction in incidence of SSP in developed nation, but same has not been seen in developing countries like India. And there was one thought that because the vaccine, which is MMR, it is also a live attenuated vaccine. So there was thought that possibly by giving vaccine also we are going to get this disease. So, but whenever this disease is going to occur in vaccinated children, so it is thought that it results from a subclinical infection, which was before that vaccination time. And when you are going to give vaccine, so infection was there already. And that's why even in some of the patients who are properly vaccinated at time, they are also going to get this SSP. But till now, there is no evidence which suggests that this MMR vaccine, which is attenuated vaccine, is responsible for sporadic cases of SSP. So regarding this pathogenesis, so measles is caused by RNA virus. It belongs to Marburg virus subgroup of paramyxoviruses. Although pathogenesis is not well established, but hypothesis says that it involves persistence of indolent brain infection with genetically variant measles virus. And it is thought that the measles virus, which reaches to brain, it is at that acute exanthem of measles, and it is through that infection of cerebral endothelial cells. And there are numerous alterations in the matrix protein, and because of this extensive point mutation in genome, which is going to change the matrix protein, it is going to possibly result in persistence of this viral infection, which leads later on to SSP. So coming to clinical features basically they vary according to the stage of the disease, and it was the clinical staging was done by Zagors and et al. So in stage 1, it consists of subacute to insidious onset of following things in variable combination like irritability, forgetfulness, personality changes, difficulty in scholastic performance, strange behavior, and this stage can last from weeks to years. Then it is followed by stage 2, and stage 2 is characterized by various type of movement disorder like dyskinesia, dystonia, and we are going to get highly characteristic myoclonic jerks in stage 2, and I will be discussing regarding this EEG finding of myoclonic jerks also in the following slides. And along with this, there are long tract motor or sensory symptoms and sign, and usually this stage is going to last from 3 months to 12 months. Then it is followed by stage 3. In stage 3, there are extrapyramidal signs and symptoms. There is flaccid or decorticated rigidity, and we are going to get signs of autonomic dysfunction. And usually myoclonus is reduced from stage 2, or it is altogether absent in stage 3. Then it is followed by catastrophic stage 4, and in stage 4 there is autonomic failure, and then loss of function of cerebral cortex, which leads to vegetative state. And usually in stage 4 there is death of the patient, usually due to cardiac failure or sometimes due to aspiration pneumonia. So although this was a typical staging, but atypical presentation can also be seen in SSP patient, which include isolated psychiatric manifestation. Then sometimes you can get this visual loss as initial presentation, and other presentation include like isolated extrapyramidal symptoms, then stroke-like onset with hemiparesis. So all these can be initial presentation, but later on patient is having that typical stage-wise deterioration, and finally a patient is going to land up in stage 4, and they are going to die if they are not treated. So sometimes what happens, there can be stabilization at one of the above stages, but it is for transient period of time, and later it is followed by again progression, and it leads to stage 4 and further vegetative state and expiry. So a few patients, they are also going to have relapsing and remitting course, but it is not very commonly seen. And regarding seizure, it can be seen in any of the above stages, but usually it is seen in stage 2 or stage 3. Regarding diagnostic criteria of SSP, it is diagnosed by Dykens et al. Criteria, which includes 5 points. And to diagnose definitively as SSP, we should get criteria 5 along with 3 more criteria. And for probable diagnosis of SSP, we need 3 out of above 5 criteria. So what are they? First one is clinical, like typical clinical presentation, subacute onset of this intellectual deterioration with that characteristic myoclonus. The second one is characteristic electroencephalographic finding of that myoclonus. Then this third one is elevated cerebrospinal fluid globulin levels, which is usually less than 20. But so in this case, it is usually more than 20% of the total protein of CSF. Then fourth one is elevated CSF measles antibody titer. It is of IgG type. And then fifth one is brain biopsy, which is suggestive for measles. So now regarding this investigations, apart from routine investigation in serum, if we are going to check anti-measles antibody titer, so it is usually raised in the titer of 1:256. In CSF study, The routine CSF study is mostly normal, apart from slightly raised this protein. And when we go for anti-measles antibody titer, it is raised in more than 1:4 titer, and CSF globulin level is most often high. It is more than 20% of the total CSF protein. And in EEG, it is the characteristic EEG is seen in second stage of the disease, where we are going to get this episodes of high voltage complexes of usually 500 to 1500 microvolts, and they are having this characteristic sharp and slow wave, and the duration of these high voltage complexes is 0.5 to 3 seconds, and they are usually occurring every 3 to 20 seconds. And most often these every complex is followed by flat pattern. But in advanced stage, we are not going to get this finding. In advanced stage, we are going to just get diffuse flowing. So here in this EEG, we can see this high voltage complexes. Here we can see sharp and slow wave complex of duration of 0.5 to usually 2 seconds, and then again there is gap of 4 to 16 seconds, and then again there is this high voltage complex. So this is typical of second stage of SSP, and this complex is known as Redemacher complex. So now coming to MRI brain with contrast. So usually it demonstrates diffuse atrophy and scarring, but in earlier stages we are going to get parieto-occipital subcortical white matter changes, and there is usually no contrast enhancement, and sometimes in some patient it can be seen, but in early stages of the disease. This is typical MRI finding, where we can see this in FLAIR and T2, this parieto-occipital subcortical white matter changes are seen. Now coming to brain biopsy, there is often evidence of extensive neuronal degeneration. There is white matter as well as gray matter involvement. So when we are going to go for frozen section examination by immunofluorescence, we are going to get this measles virus antigen, and RT-PCR of that sample can also detect various regions of this viral RNA. And because this viral infection is also going to cause infection of oligodendrocytes, so that's why we are going to get in SSP extensive demyelination pattern also. But in advanced stages, this gross examination will reveal diffuse, mild to moderate atrophy. Functional imaging usually not required, but in those patients where MRI is normal in early stages, we can go for functional this stage imaging like PET to get something abnormal. And regarding this treatment, till now there is no adequate therapy which is available for treatment of SSP, but from different non-randomized trials, they suggest that different antiviral and immunomodulator agents, they can prolong the life of patient if taken for extended period. So first and foremost is isoprinosine. We all have heard the name of this medicine. It is basically antiviral drug which acts as a immunomodulator, and it activates the body's immunological response against this measles virus, and it is going to easily increase the number of CD4 counts, then augments natural killer cell function, and it is going to increase the production of interleukin 1 and interleukin 2. So the usual drug dose is 100 milligram per kg per day, and it is not usually having much of side effect. But what even after patient is going in remission, the medicine is to be continued for extended periods, sometimes possibly for lifelong. Then second medication is interferon alpha. Actually, the studies have shown that CSF interferon levels are found to be low in SSP patient. So exogenous administration of interferon theoretically is going to suppress the viral replication, and that is the theory behind giving this interferon alpha mostly through intraventricular route. So initially it was given by intravenous or intrathecal route, but it was not having that good benefit. But later on, this Panigen et al., they were the first one to use this interferon alpha through intraventricular route throh Meyer reservoir, and they followed this standard regime of 6 weeks course, first 1 lakh unit per meter square, then subsequently 1 million unit per meter square, and the course was repeated up to 5 or 6 cycles in 2 to 6 month interval with variable success. So combined treatment of oral isoprinosine with intraventricular interferon alpha appears till now the most effective treatment for SSP. And throughout this treatment, CSF, measles antibody titer, renal and hepatic function needs to be followed. And like other medications with variable benefit, till now they have been tried like ribavirin, amantadine, IVIG, plasmapheresis, and corticosteroid, but they have not been included in a standard treatment protocol because there has not been much benefit after giving all these medications. So, regarding symptomatic
Hello.
treatment,
Hello. Sorry to interrupt. Dr. Pandey, I think we'll have to expedite a little bit since we are running out of time.
few slides more. The
Yes,
symptomatic
ma'am.
treatment is good nursing care, and it is most important aspect of management of SSP. Anticholinergic like sodium valproate and clonazepam, they are helpful in controlling myoclonus, and spasticity can be controlled by giving baclofen or other anti-spasticity medication. Prognosis, it is progressive disorder and death is inevitable in next 1 or 3 years, but in 5% of the patient there is sometimes spontaneous remission. And to summarize, it is basically a slow viral infection producing inflammatory change of whole of the brain and subsequently death of neurons. In developed country, it is a rare disease, but in developing countries like our country, India, it is still having a significant number of patients. Isoprinosine was the first drug tried in SSP. Then came alpha interferon. Now both are given in combination, and this is sometimes going to give very good result, and up to 25 to 30% of the patient it is going to give stabilization or improvement in SSP patient. Thank you all for listening.
Thanks, Sudhakar, for that comprehensive review on SSP. I hope that will help our students write a short or long question on SSP. So we move forward. We are running short of time. So now we have got a next speaker, and he is going to speak on neurological manifestations of HIV. Vishal, are you there?
Yes, sir.
Yeah, so you can please share your slides, and let us hope that you will be on time. Thanks, Vishal.
Yes, sir.
You can
Sure.
share your screen.
Good evening, everyone. Myself, Dr. Vishal Gaikwad. Today, my topic is neurological complications of HIV. And obviously, there could not be any better day than this World AIDS Day to have this topic to discuss. This is basically the poster of World AIDS Day for 2020. Just to introduce, as we all know that in 1981, AIDS was first introduced because there were multiple cases of pneumocystis carinii pneumonia and Kaposi sarcoma, which were detected in US. And till now, HIV is again the most viral infection of the nervous system, which can affect both central nervous system as well as the peripheral nervous system. After Africa, sub-Saharan Africa, India is the second largest burden for HIV-related pathology. To discuss pathophysiology, HIV can actually affect central nervous system by both direct and indirect ways. By direct ways, it can infect the macrophages and monocytes, and it will enter the already damaged blood-brain barrier and will carry virus with them. The most common locations for the virus are basal ganglia, subcortical regions, and the frontal cortex. And that's why the disorders will be and the manifestations will be according. Once it reaches all these areas, these infected macrophages and the microglia cells will then elaborate certain other pro-inflammatory cytokines like TNF-alpha, cytokines, interleukins, chemokines, and the nitric oxide, and will have their manifestations. By indirect way, I meant that it can cause other opportunistic infections also by not directly infecting, but by providing a suitable environment for other opportunistic organisms to infect the brain. So almost all the neuroanatomical substrates are affected by HIV, ranging directly from meninges, brain, spinal cord, radical peripheral nerves to muscles. But there are certain AIDS defining illnesses, which I'll be discussing with you for the further talks. If we discuss the CNS disorders, depending upon the neuroanatomical sites or neuroanatomical localization, in meninges, aseptic HIV meningitis and cryptococcal meningitis are the most important things. Other than that, TB can cause meningitis, syphilitic meningitis, listeria, as well as lymphomatous meningitis are the another CNS disorders. In brain, there are non-focal and there are focal CNS disorders. In non-focal CNS disorders, HIV-associated dementia is the AIDS-defining illness. Other than that, Toxoplasma encephalitis, CMV encephalitis, Aspergillus, and herpes also can cause encephalitis. In focal, cerebral toxoplasmosis is the most common mass lesion in the CNS in AIDS patient. Other than that, PCNSL, that is primary CNS lymphoma, and progressive multifocal leukoencephalopathy. Other than that, tuberculoma and VZV encephalitis could be the focal affection of the brain. In spinal cord, vacuolar myelopathy is the most common and most important pathology. Other than vacuolar, CMV, VZV, STLV, all these could cause myelopathy. In peripheral nerves, AIDP, CIDP, cranial mononeuropathies, multiple mononeuropathies, DSPN, which is the most common, and other than that, autoimmune and CMV polyradiculomyelitis could be the CNS disorders. And in muscles, the most important would be AIDS cachexia myopathy. Other than that, polymyositis, pyomyositis, inclusion body myositis, and toxic myopathy, zydorinduced, could be the CNS disorders. So now we will discuss one by one. The first would be aseptic HIV meningitis. Aseptic HIV meningitis is usually seen in patients of acute seroconvergent illness, where they actually present with flu-related illness or febrile illness, and they present with just persistent headache. These aseptic meningitis patients won't present with loss of alertness or loss of cognition or typical meningitic signs. There will be just persistent headache along with flu-like febrile illness. And in acute seroconvergent patients, 10 to 15% of such patients may have aseptic HIV meningitis. Basically, it is a diagnosis of exclusion. So you need to rule out all other causes of meningitis like TB, CMV, and all those. And if those are ruled out, then this could be the cause of meningitis. To diagnose it, like all other meningitis, CSF won't be much contributory, but it may suggest a normal sugar. Protein will be elevated, but will be less than 100. Cells, there will be lymphocytic pleocytosis less than 25. The other things which may point towards aseptic meningitis would be presence of intrathecal anti-HIV IgG antibody, and other things like HIV RNA level or serum P24 capture assay may corroborate the other evidences. Treatment, aseptic meningitis, there is no specific therapy that is needed. Usually with heart only, it resolves in 2 to 4 months, and other symptomatic managements for headache, for flu-like illness could be given. Now, the next most important thing would be AIDS dementia complex or HIV encephalopathy. It has multiple names like HIV dementia, AIDS dementia complex, subacute encephalitis, HIV encephalopathy, HIV-1 associated cognitive motor complex. Usually, these occurs in patients with CD4 count of less than 200. In asymptomatic phase of HIV, it just accounts for 0.4% of the cases. In late stages of HIV, it could be present in 7.5 to 27% of the patients. If you see the pathophysiology in the brain biopsy or autopsy of the patient, in HIV encephalitis, the characteristic feature is multinucleate giant cell and other inflammatory cell infiltrations like macrophages and monocytes. And in leukoencephalopathy, the most characteristic feature is presence of white matter pallor along with reactive gliosis. The cerebral cortex is comparatively spared. Features of HIV dementia, these patients usually present with forgetfulness, decreased attention and concentration, inability to perform complex tasks, memory loss, gait disorders, slowness in movement, and postural tremors. There is no specific diagnostic test or there is any criteria to diagnose HIV encephalopathy. To diagnose the dementia, you just have to demonstrate presence of decline in the cognition. So it is always mandatory to have a basic MMSE done whenever you diagnose a patient of HIV. The clinical staging of HIV encephalopathy is done based on two things. One is cognitive function and second is motor function. So ranging from stage 0 to stage 4, the mental function and the motor function could range from a normal from stage 0 to major intellectual or major motor disability. So to confirm the dementia, neuropsychological testing will be very important. The decline in MMSE will be a good guide to diagnose dementia. The second thing, MRI, but MRI won't be of a diagnostic conclusive thing because it will just show presence of diffuse cerebral atrophy And along with that, there could be patchy and other diffusely abnormal signals, mainly on flare image, T2 flare image in white matter in basal ganglia and in thalamus. CSF sugar will be normal, protein may be mildly elevated but won't be less than 100, won't be more than 100. Cells lymphocytic pleocytosis less than 25. There are other special tests which are of less practical utility, of which presence of beta 2 macroglobulin and neopterin will have some value. Other than that, HIV IgG synthesis, oligoclonal bands, presence of HIV DNA amplification, all these have less practical utility comparatively. So this is the T2 flare image on my right side, and on the left side there is a T1 image. This is showing diffuse cortical atrophy. Along with that, there is a mild periventricular ischemic pallor. This is a classical MRI of HIV dementia patient. Treatment wise, heart is the most important treatment for HIV dementia patient, because it is the one which improves neuropsychological performance in these patients. Uh, since the inception of heart, there is 50%, almost 50% reduction in patients of HIV encephalopathy. So all those drugs with high CSF penetration should be used. Like zidovudine can be used up to maximum dose of even 1000 milligram. Other than that, stavudine, lamivudine, efavirenz, nevirapine could be used. Other than heart, neuroleptic medication for behavioral symptoms could be used, but they should be used with caution, because they may have a tendency and sensitivity for extrapyramidal syndromes. So TCAs, tricyclics can be used, SSRIs can be used, clozapine and haloperidol should be used with caution. For anticonvulsant, topiramate and gabapentin are to be the preferred one. And other than that, like in other dementia patients, psychological support, family support, assisted living has to be another cornerstone for the treatment. The next most important thing would be cryptococcal meningitis. Cryptococcal meningitis, it is the most common CNS fungal infection in patients with HIV. It occurs in patients with CD4 count of less than 100. Again, as compared to normal meningitis, these patients usually again won't have typical neck stiffness, typical photophobia, which usually they are absent. The presenting feature will be often subtle, and they will be very non-specific, like malaise, fever, nausea, vomiting, and headache. Other than that, cranial nerve palsies, psychiatric abnormalities, speech therapies, and seizures could be the presenting symptom for cryptococcal meningitis. But this will not give any diagnostic conclusion or etiological conclusion, just based on the clinical features. So we need support of investigation. MRI is fairly specific. If there is presence of gelatinous pseudocyst, second, along with hydrocephalus or cryptococcomas, that may give a clue to the cryptococcal infection. Along with that, CSF again will be classical, with sugar will be low, proteins will be elevated, and cells will have a mononuclear pleocytosis. But it could be another differential for TBM with low sugar. India Inks is actually a non-specific test, but if it is positive, it will suggest that the sensitivity is pretty high, the specificity is comparatively low. CSF cryptococcal antigen, it has a high sensitivity of 95%, but the gold standard would be fungal CSF culture for the cryptococcus. This is a T2 image. It is showing multiple gelatinous cysts in the basal ganglia region. These are basically the CSF intensity lesion, and along with that, there is a diffuse cerebral cortical atrophy, which can be seen in cryptococcal meningitis patients. Coming on to the treatment part, the treatment is same as any fungal treatment, but it has an induction phase and it has a maintenance phase. In induction phase, you start with amphotericin with or without flucytosine in a dose of 0.5 to 0.7 mg per kg per day. And flucytosine, if used, could be used at a dose of 75 to 150 mg per kg per day. You look for the side effects of amphotericin, mainly the renal side effects, and flucytosine, mainly hematological side effects. And it should be continued for a period of 2 to 3 weeks. Once the induction phase is over and patient is improving, we can convert it into the maintenance phase of fluconazole, total 400 milligram, 200 milligram per oral BD. It should be continued for next 8 to 10 weeks, and this should be followed by maintenance of fluconazole 200 OD, and it should be continued either lifelong or till the CD4 count is more than 200. If the patient has hydrocephalus or signs of raised ICP, then medical management like corticosteroid or acetazolamide can be given. And if needed, surgical options like repeated lumbar puncture and ventriculostomy could be used for these patients. The next mass lesion would be cerebral toxoplasmosis. It is the most common cerebral mass lesion, and this toxoplasmosis can spread either hematologically to the brain, or there can be just reactivation of these latent organisms which are actually present in the brain. Symptoms would be again very non-specific, like headache, confusion, fever, lethargy, seizure, hemiparesis, ataxia, and cranial nerve palsy, depending upon the presence of or site of toxoplasma. Investigations are fairly specific. If we do the MRI, there will be multiple ring enhancement lesion in multiple locations. It may mimic like TB lesion, or it may mimic like lymphoma lesion, but there are subtle differences in the ring. In TB, the ring will be comparatively thick. There may be central necrosis. The ring is usually regular. In toxoplasma, the rings are usually irregular. Comparatively, they are bigger lesion with mass effect, and these may also have central necrosis. The diagnosis or the confirmation could be done by presence of IgG antibody to the toxoplasma. So basically, the crux is, if there is any ring enhancing lesion in HIV, you treat the patient as toxoplasma for 2 to 3 weeks, and if it is not, then you can go for brain biopsy. So go for MRI, multiple lesions, then go for IgG antibody to the toxoplasma. If it is positive, well and good. Start with the treatment of toxoplasma. If patient improving within 2 to 3 weeks, good. If not, go for brain biopsy. Brain biopsy is the ultimate confirmatory test. So this is the typical case of toxoplasmosis, where there is a thin rim, irregular enhancement, and multiple sites. Treatment, the gold standard treatment for toxoplasma is sulfadiazine plus pyrimethamine. If the patient has sulfa allergy, clindamycin also can be used in place of sulfadiazine. It should be used with folinic acid. And for long-term suppressive therapy also, sulfadiazine plus pyrimethamine combination has to be used. It should be continued in a maintenance dose for lifelong, or till the CD4 count is more than 200. The next important thing, primary CNS lymphoma. Incidence of CNS lymphoma usually occurs in patients with CD4
Vishal,
count.
sorry to interrupt.
Yes, sir.
Yeah, I mean, we are already around 9:45, so if you can just.
I'll hurry up, sir.
Yeah, thank you.
Yeah,
Thank
sure, sure, sure. So CD4 count of less than 100, clinical features will be same as toxoplasma. But if there is a single lesion on MRI, particularly in persons with with absent antitoxoplasma antibody, it may favor the diagnosis of lymphoma. So MRI is fairly diagnostic. One or more deep lesions, location, deep white matter rather than gray matter. Subependymal extension, again characteristic. CSF is not of much help, but if CSF flow cytometry, that may help the patient. Presence of EBV virus DNA amplification, again, may add a corroborative evidence for the PCNSL. Brain biopsy is the most definitive diagnosis for lymphoma as well as toxoplasma. So these are the MRI pictures and CT pictures. Treatment wise, continuation of heart. If there is a mass effect, continue corticosteroid therapy, and palliative whole brain radiotherapy is the treatment of choice for lymphoma patients. PML. PML is caused by JC virus. Patient usually present with altered mental status, visual disturbances, and other features. Investigation wise, MRI is very characteristic presence of multiple non-enhancing white matter lesions, and they have a predilection for the occipitoparietal region. In CSF wise, no specific changes except if presence of CSF PCR for JCV virus DNA, it has a very high sensitivity of 76%. Brain biopsy, if there is a clinical diagnosis with suspicion of a PML, but no viral DNA for JC virus, then we can go for brain biopsy. This is the typical MRI brain picture. This is basically demyelination secondary to infection of the oligodendrocyte by the JC virus. Treatment, no specific treatment per se for PML, just continuation of the heart is the only treatment of choice. Other modalities can be tried, but they have unsatisfactory. This is very important chart taken from Bradley. If patient present with CNS manifestation, just go for neuroimaging, any CT or MRI. If there is if there is no focal lesion, go for CSF and search for specific cryptococcal, TB, HIV, or syphilis. If there is focal lesion, single or multiple, if there is ring enhancement, go for toxoplasma serology. If it is positive, treat the patient. If there is improvement, continue the patient as a case of toxoplasma encephalitis. If there is no improvement, or if toxoplasma serology is negative, go for CSF analysis and look for CMV, EBV, PCNLS, and if still there is confusion, go for serotactic biopsy. The two slides just. The most important is, again, the next important is spinal cord. Vascular myelopathy is the most common, of which clinical features will be typical like myelopathy, like slowly progressive muscle weakness, lower extremity sensory complaints, sphincter abnormalities. MRI spine will show cord swelling in early stage and cord atrophy in later stages. You just have to exclude the other causes of myelopathy like CMV, VZV, and HSV. Treatment wise, you just continue with the heart and other symptomatic management for the myelopathy. DSPN, the symptoms will be typical burning sensation, numbness mainly involving lower limb, no involvement of the upper limb. Investigation wise, NCV will confirm the presence of sensory involvement. Neurotoxins like NRTIs, ethanol, and INH should be removed from the treatment. You have to find out other causes of sensory neuropathy like vitamin B12 deficiency and diabetes mellitus, and if they are present, you have to treat it. Symptomatically, heart and painkillers like nortriptyline and anticholinergic like gabapentin could be used. Myopathy can occur at all stages, presents with myalgia and weight loss. There are no confirmatory features, but CPK total may be raised, and EMG may confirm presence of myopathy. If it is myopathy, just withdraw the zidovudine if it is present. Give prednisolone therapy and physical therapy depending upon the patient. So to conclude, HIV has multiple central and PNS problems. You just have to diagnose them correctly, which may change, and if you treat them at the right time, patient will have a better quality of life and survival time. Thank you.
Thanks, Vishal, for the comprehensive review. And now I request Dr. Sagar Bitai. He's from a young neurologist from Ahmedabad. So he is going to enlighten us with CJD. So Sagar, you can please share your slides.
Yeah, sure, sir. Okay, is my presentation visible?
Not yet, Sagar.
Okay.
Yeah, now it's visible.
Okay. Good evening, friends. I'll try to be as quick as possible. I will discuss about Creutzfeldt-Jakob disease today with a special mention of the new variant CJD type. Just to introduce, it is the prion protein is something between a protein and a virus or the virion, and hence it is called prion. It has structure like protein, and it is infectious and transmissible from cell to cell in an intracellular fashion like a virus. But unlike a virus, it does not have nucleic acid, and it fails to produce any sort of immune reaction in the host, and hence there is no inflammation in the imaging or the biopsy findings. It is a normally coded protein, otherwise PRP, which is a very benign, harmless protein present in all of us on short arm of chromosome 20. But when there is a misfolding, it acts as a scaffold and multiplies this misfolding proteins, which can transfer from cell to cell in the nucleic acid. And hence it propagates and causes a degenerating type of effect on the neurons, and hence leads to gliosis. And the biopsy is very much like any neurodegenerative disease like Alzheimer's or frontotemporal dementia, or like a degenerative Parkinsonism. So there are two stains which can demonstrate on autopsy or a biopsy. One is the simple H&E stain, which would show spongiform changes in the layer 2 and layer 5 of the cortical gray matter, as well as the deep gray matter. And also it will show the signs of usual degenerative like disease, which may fox an appearance of a dementia, a degenerative dementia, like the accumulation of amyloid, tau protein, alpha-synuclein, and ubiquitin, like any other degenerative condition. And the other stain which stains it is the stain, IHC stain specific for PRP, and which will specifically demonstrate the prion proteins inside the cortical and the subcortical gray matter. And because there is spongiform appearance on the H&E stain, it is also called subacute spongiform encephalopathy, because it is subacute, which means it progresses rapidly over weeks to months, unlike a typical dementia. So what are the clinical features of CJD? The clinical features are that of dementia-like syndrome, but to be more specific, it is a rapidly progressive dementia-like syndrome. And what do we mean by rapidly progressive? For dementia, which generally takes years to develop, rapidly progressive would mean less than 2 years to develop. And so it is one of the differential diagnoses of RPD. And it is common in 6 to 7 decades, also overlapping with diagnosis of the neurodegenerative dementias. So the primary features are cognitive decline and multifocal or generalized myoclonic jerks. So these are the two hallmark features which progress over weeks to months. And by cognitive decline, generally there is a lack of and decline of intelligence, memory, attention span, judgment, various types of aphasia and other cortical deficits, and which include apraxia and visual agnosia as well, accompanied by myoclonic jerks. So if these two are present, which are rapidly progressive, there is a good chance that it may be a CJD. I will also discuss the other mimickers, which can look like CJD but are more treatable than CJD. After a few weeks to months, there come behavioral abnormalities, sometimes early also, in the form of either depression, apathy, socially withdrawn behavior, and sometimes agitation and hallucinations or delusions. Cerebellar ataxia in the form of an abnormal and ataxic gait, as well as a cerebellar type of dysarthria are also common features. And in a moderate to advanced stage, we will also have extrapyramidal symptoms in the form of rigidity, bradykinesia, hypophonia, and eventually an akinetic rigid state. So there are three, in fact, there are 4 types. The most common, by far the most common one is sporadic, which is a sporadic mutation-like conformational change in the prion protein in any index case. And which the type which I have not mentioned here is around 10 to 15% possibility of a genetic variant, which transmits genetically in autosomal dominant fashion. Uncommonly now, there is an iatrogenic form which initially used to be transmitted by organ transplants, especially corneal transplant, and sometimes via blood transfusion, which is not so common now, via the leukocytes, the dural grafts, sometimes the cortical electrodes, but now the special precautions generally avoid this transmission. And the variant CJD, which is very rare, even in cases of CJD, is the one which was found very recently in 1996, starting in and as an epidemic in the cows and through beef eating transmitted to human beings, first found in UK. So discussing about new variant CJD, which we commonly call variant CJD, the age of onset is earlier compared to a sporadic CJD in second or third decade. The symptoms in general overlap with sporadic CJD, like a rapidly progressive dementia syndrome, but the hallmarks of initial presentation are psychiatric features and the sensory features. So in psychiatric, the most common feature in 80 to 90% cases is depression and withdrawn behavior, flattened affect, which is apathy, sometimes agitation, hallucinations, and vague tingling and painful symptoms on the limbs and face. But objective findings are less commonly demonstrable. It is more of a subjective complaint rather than an objective examination finding. And then comes, after initial months, there comes the onset of cognitive decline. Unlike in sporadic CJD, where there is an initial decline in the cognition during presentation. So the cognitive decline, ataxia, myoclonus, this triad comes later on. And the diagnostic criteria, which were founded in 2011. So all of the following criteria are required to diagnose a probable case of new variant CJD. A definitive case would be, of course, an autopsy, because biopsy generally not possible in the live brain. So the probable diagnostic criteria are new onset neuropsychiatric features, which last more than 6 months. And 4 of the 5 following are required as clinical features, like the early psychiatric features, persistent painful sensory symptoms, ataxia, myoclonus, and dementia. So at least 4 are required. Very importantly, no alternative diagnosis, which I'll discuss after a few slides. How do we look for the alternative diagnosis, which are more important actually than to diagnose CJD because they are more treatable. A positive biopsy from tonsils. This is, I think, a very important thing, which is not possible in a sporadic CJD, but somehow the variant CJD, although it is the same prion protein, but it has more affinity toward the lymphoid tissue. And in lymphoid, specifically the tonsils, so the tonsillar biopsy also shows the same findings as found in the brain biopsy. And these findings are in the leukocytes in the tonsils. So either a positive biopsy from tonsils or the typical MRI findings, which I just discussed, are required, one of these two. And absence of periodic sharp wave complexes on EEG, which are generally a hallmark and I would not say specific, but quite sensitive finding and a reasonably specific finding in a typical setting of a sporadic CJD like case. The typical periodic sharp waves are of around 1 to 2 hertz frequency with a progressively slowing background as the disease progresses. But the point I'm trying to say is that in the variant CJD, these periodic sharp wave complexes are absent. So what I was mentioning in a sporadic CJD, after a few weeks to a few months, there would be an onset of a reasonably periodic sharp waves at around 1 to 2 hertz. In this case is 1 hertz, and with slowing of background. And generally it correlates with the synchronicity with the myoclonic jerks clinically. And they also happen without myoclonic jerks in an advanced stage. And the MRI would show cortical ribboning as a hallmark on a diffusion weighted image, which is the diffusion restriction of the cortical gray matter. So it is asymmetric right now, but then gradually it starts becoming symmetric and throughout the fronto temporoparietal and occipital cortex eventually. There is also diffusion restriction and corresponding hyperintensity on flare of the head of the caudate, the putamen, and even the globus pallidus eventually. So all lentiform nuclei are involved in case of sporadic CJD. So these MRI findings have sensitivity of more than 90%, and in a typical setting, a specificity as well of more than 90%. And it can be mimicked by anoxic brain changes. So coming to the variant CJD, so how is it different from the sporadic CJD? So the diagnostic test in the variant CJD, the MRI brain is reasonably specific. I would say more than 90 to 95% specific in around 3 studies, and it shows a pulvinar sign. The pulvinar subnuclei of the thalamus are specifically an early stage involved. So it shows a hyperintensity on flare as well as a similar diffusion restriction on a DWI image. And it is also called the hockey sign, which shows the end of the hockey stick like appearance on both sides. As I already mentioned, the EEG is normal in early stage, and in later stages, it shows a non-specific slowing of the background. The CSF study is normal. So the more common importance of a normal CSF study means that there is no inflammation, and hence the mimickers of CJD like the autoimmune encephalitis or the paraneoplastic or infectious encephalitis are not there, rather than ruling in CJD. Protein 1433 is not a sensitive nor a specific marker of CJD, and even the variant CJD, so not of much importance to diagnose. The tonsillar biopsy by Western blot or IHC staining can diagnose CJD very specifically. So I would say the biopsy and the MRI findings are very specific for variant CJD. And I think the most important thing, although may not be of use in the exams for students, but a workup for CJD mimicker should definitely be pursued as soon as we suspect a case of CJD, because CJD, as we know, has like 100% mortality. So there should be made every effort to avoid a death sentence of a patient. So for me, this is the most important slide of the talk, because I would be keen to have a differential diagnosis of this rapidly progressive dementia-like syndrome of CJD. So in a variant CJD, a primary psychiatric illness or new onset of dementia or schizophrenia may be in a picture, especially in a patient in 6th or 7th decade. I would suspect that why should a patient have a new onset of depression who has never had depression in his life, or which is resistant to the treatment by antidepressants. The neurodegenerative dementias are the most common confusion and the most common diagnosis found in the suspected case of CJD initially, which does not turn out to be CJD. And just by the sheer incidence of Alzheimer's and frontotemporal dementia, um, they generally progress over many years, more than 2 years. But in patients who have progression in less than 2 years, still Alzheimer's and frontotemporal dementias are the most common diagnosis. Autoimmune and paraneoplastic encephalitis, including the VGKC and NMDA. And in paraneoplastic, the small cell lung cancer is the most notorious malignancy to cause a limbic-like encephalitis, which includes psychiatric symptoms, encephalitis, hyponatremia, and facial-brachial seizures, new onset of seizures, myoclonic jerks. And it is more common in the young female groups who may also have SLE or any other vitiligo, hypothyroidism, or other autoimmune conditions like rheumatoid arthritis as well. And the other contention in autoimmune category is the Hashimoto's encephalitis, which can also have rapid cognitive decline, myoclonic jerks, sometimes specifically stroke-like episodes, which are completely reversible and again happen in reverse. They may have or may not have even sometimes anti-TPO and thyroglobulin antibodies. So there is no relation with the thyroid function for Hashimoto encephalitis, but it can sometimes have strongly elevated TPO antibodies. But we should keep in mind that anti-TPO antibodies are common in 10% of normal population as well, and especially in people who have a history of thyroid disease. So we should be aware before we make a diagnosis of Hashimoto's. But by definition, it is a steroid responsive encephalitis. The infectious encephalitis, very important differential of CJD-like syndrome. So a CSF study, ESR, CRP, history of fever would be very easy, and neck rigidity would be very easy to diagnose an infectious encephalitis. And as I already mentioned, that CJD does not elicit inflammation, and hence there is no contrast enhancement of the lesions, and there is no cells on CSF, and even the systemic inflammatory markers are absent. So commonly herpes simplex encephalitis, sometimes even SSP can mimic it, and sometimes the Whipple disease, which would have a systemic involvement in the form of fleeting arthritis, diarrhea, abdominal pain, and having oculomastocatory myorrhythmia, which means the synchronous movements of the eye convergence-like movements and the rhythmic jaw movements happening along with it. So that would be a very specific finding for Whipple's. In patients who are malnourished, who have history of chronic alcoholism, or even sometimes chronic renal failure disease patients would have a severe riboflavin deficiency or a thiamine deficiency, which would have rapid cognitive decline with myoclonic jerks, ataxia. And again, this also is very much reversible by supplementing with high dose of riboflavin and thiamine. So they should be very well kept in mind, and the history of alcoholism and severe malnourishment due to any cause should be always pursued. Celiac disease, for the same reason of malnutrition, can also lead to similar picture. And uncommonly mitochondrial disease, or especially intravascular lymphomas, and many that like things like PML can also mimic CJD. So there is no cure, unfortunately, of CJD. But I mean, in 5 patients trial, I could review a paper which showed that pentosane polysulfate, which was given intrathecally and intraventricularly, delayed death by a year or 2 in 5 patients. But again, this is no substitute for a cure of any sort. And always in patients in which there is a doubtful case, in which we are not convinced that it is CJD, especially in the early cases, or patients who show inflammation in CSF or in systemic, the serum markers, or having any type of systemic autoimmune disease, and patients who have, say, normal MRI, we do not show a typical finding of CJD on MRI. We should always search for and sometimes even empirically treat the mimickers of CJD. And there is no protocol of that sort, but commonly I would say we should use a cocktail of empirical treatment, which includes acyclovir for herpes simplex encephalitis, intravenous high dose of methylprednisolone for the various autoimmune or paraneoplastic encephalitis, and even Hashimoto's. And in a patient who may have suspected malnutrition of alcoholism, we should use high dose of thiamine and riboflavin. And to our surprise, this may sometimes treat the patient very well and reverse all the symptoms. And if you want to pursue it further, if there is a significant improvement on steroids or in further suspicion of an autoimmune encephalitis, we may also try immunotherapy like IVIG or plasma exchange if we have some clue. So I would end my talk compensating for the time lost already. Thank you.
Yeah, thanks, Sagar. That was an excellent talk on CJD as well as the novel variant. And as far as I can see, there aren't any questions right now, up till now. So all the participants, if there are any questions, we can take few questions. We have got our speakers right now. There are no questions, so we will probably conclude the session. Thanks, Sagar, Vishal, Dr. Pandey, and Dr. Sweety for your valuable inputs, and I hope it would be helpful for our students and even the clinicians like us to help out treat our patients better. Thanks, Sudhakar. Thanks, Sagar. Thanks, Vishal.
Thank you.
Thanks, Dr. Sweety. So we will end the meeting. And thanks everybody for participating. The next lecture probably would be on next Tuesday. We will update you regarding the same.
Thank you all.
Thank you.
Thank you, sir.